back. So I want to introduce him, tell him thank you. He's going to present here today, and then he has to run. He is specially here for us today for this presentation. So I hope you guys enjoy him, and thank you very much. Thank you, Mr. McFarland. Thank you. Give him a round of applause, everybody.
Well, good morning. And I'll just warn you right now, I'm not a standstill person, so I'm sorry the tape is going to be, anyway, I can't stand still. Anyway, glad to be here. Can you hear me all right in the back? Okay. Just give me a thumbs if I'm not loud enough. Okay. Military culture, since we'll just take up where Dr. Exum left off, on one of the handouts, you'll notice the word CONUS. What does that mean? Continental United States, so stateside. So when we talk about our deployed people, we're talking about OCONUS, outside the continental United States. Just a little tidbit, won't charge you for that, okay? That's it. I'll tell you right now, we're not going to get through with all the stuff you have. All right? So we'll get as far as we can. We'll certainly get the highlights of what I think is important. Some of the others just wanted to make sure you had access to that. I feel out of place. I'm the only non-doctor, so I'm just a lowly LMFT. So.
You're young, you can start.
Oh, if you only knew. Anyway, all right. Stick with me as we kind of walk through, because I want to lead you down a process. But before we get started, I think it's really important that we understand why we're here and why this topic. These are the young men and women that we're talking about. Men and women who have given their lives in service of this country, but who have died by suicide. And I know I'm talking to the choir here, but I always want to emphasize when I have a chance to whatever the audience may be, these are not bad soldiers. These are not cowards. These are men and women who, for whatever reason, found themselves in a great deal of pain and were unable to see any other option and died by suicide. And so what I want to talk to you about from now till a little bit before lunch is how you and I can engage those who are still living to prevent adding more to this picture. Okay? So think with me just for a minute as we kind of walk down a pathway. But before we do so, you'll find in your packet a little case management. This is Hank, not actually Hank. I put a fake photo up there because I wanted us to have a person to relate to as we think about this case example, okay? I'm just going to read this to you as a setup. Hank is a 24-year-old Operation Iraqi Freedom combat veteran. He joined the Army National Guard soon after the attacks of 9/11, and he served until February 2006. Hank spent a total of almost 2 years in Iraq in the course of 2 separate deployments. His duties involved a high-level communications. During the time that he was in theater, he was exposed to multiple IEDs. One such attack ultimately wounded his right leg, which led to his medical discharge and disability compensation from the VA. Just a note as I'm thinking about that in terms of linking this with what we've just heard. It's very difficult for a service member who is so fit-oriented to hear the word disability or unfit for duty. And so many times they get sent for a fitness of duty evaluation. That's a tough process when you start questioning my fitness. Okay? So just, hear that. Sometimes our servicemen and women are not real eager to seek disability because of where that puts them in their own minds and in the minds of others. It's a tough place to be. When asked about traumatic combat-related experiences, Hank recalled seeing many multiple bodies of Iraqis and witnessed 4 fellow soldiers being shot and killed. Hank grew up in Colorado Springs in a military-friendly environment. After 9/11, he felt compelled to do something for his country. He thus dropped out of community college and joined the Army National Guard. Since returning from Iraq, Hank has experienced significant breakthrough symptoms of PTSD, including startle response, flashbacks, hypervigilance, nightmares, and social avoidance. At the time of intake, Hank reported feeling hopeless about the world and his future and endorsed persistent suicidal ideation and had recently held a gun to his head. Hank had not been using alcohol or drugs, although in the past this had been a means of coping, and he worried about falling back into those old habits. He spends most of his time sitting in his apartment watching TV and thinking about his experiences in Iraq. Hank is relatively isolated and has limited contact with friends. He does regularly speak to his parents and siblings who are worried about him. I want you to get that scenario in front of you. We're going to come back to it, but I want you to be thinking in the back of your mind, if Hank showed up in my office, what would I do with him? Where would I start? Okay? Kind of sets the stage. So think with me for just a moment, because we've got a pretty disturbing picture that we've got to get in front of everybody. From a public health perspective, we've been involved in this thing called suicide prevention for a pretty long time, haven't we? We've thrown a few dollars at it. And yet in 2009, which is the most recent national data that we have, it's gone from the 11th leading cause of death to the 10th leading cause of death. It's getting worse. You can see the data there. You say, Mike, what's the point? I thought we were here to talk about the military. We are. Be very cautious about being real critical about the military. When are you going to get your hands on the suicide problem when we haven't been able to get a hold of it in a public health way? The military is only now beginning to kind of see how significant this problem is. It's not going to go away soon. But be very careful about criticizing the military, unless we can do a better job in the public health sector. Okay? Obviously, you can see my biases, and I get passionate about that. So, but obviously, as you well know, this is a significant problem in the military, isn't it? We'll talk some recent statistics here in just a minute. But I just want to get this in front of you. So it is a public health problem. It is a military problem. It is a people problem, because wherever you find people, this is going to be an issue. Okay? So, now more than ever, it is important that there be clinicians who are competent to deal with the suicide issue. All right? It becomes increasingly more necessary for you and I to be competent because the rules of mental health have changed as well. The days of extended hospital stays are gone forever, which means you and I, as civilian therapists, have to handle higher and higher risk clients in an outpatient kind of setting, which means we've got to be very competent. Now, what I'm about to show you is not a comment on the people in this room. I don't know you. But it is a statement about, or a description of an overall condition that we need to be worried about, given what I've just told you. Okay? 11 years ago, and the public sector, when we started in 2001, the National Strategies for Suicide Prevention stated this: many mental health professionals overall are not adequately trained to provide proper assessment, treatment, and management of suicidal clients, or know how to refer them. That was 11 years ago. Is it any better? Well, let's see. This was an article written by some of the nation's top researchers in the area of suicidality. We'll be talking a little bit about David Jobs and his model here in just a little bit. But in 2008, They wrote this article, and competency issues related to suicide tend to haunt contemporary providers. And these were the issues that they outlined that tend to be kind of the bugaboos that you and I as therapists have to deal with, that we're not real competent. That was 2008. So from 2001 to 2008, not a lot of good news, right? Has it gotten any better? I want you to notice what they concluded in that 2008 article. Notice that. Given these concerns, experts have argued that contemporary clinical care of suicide risk is largely inadequate. Now, you're beginning to you get this? We've got a public health problem, a military problem around suicidality, and yet the researchers are telling us the folks who are charged with managing suicidal clients are largely not competent and are providing inadequate care. Not good. Particularly when you see the nexus that's happening, because in the public specter, we have suicide awareness training and all that, which are increasing people's awareness, which then is pushing more and more people into the mental health system. But if we're pushing more and more people into the system, but we don't have therapists who are competent to handle them, frustrating. Again, this is not, I don't know you, this is not an indictment of you, okay? But it is cause for concern about the overall system, isn't it? Has it gotten any better? That was 4 years ago. 2012, finally. What do you notice? Huh? Wow. What the? Never. I'll watch my language here. I got to remind myself I'm not with military folks, so can't be free to speak.
So 4 years we've gone from largely inadequate to woefully. That sounds worse.
Good for you to pick that. Well, you know, you don't know what the descriptors are, but
still.
Again, we're not going in a good direction. So, again, the reason why we want to spend some time, not that you're necessarily incompetent, but it's important that we begin to make sure that there is a degree of competency out in our field, right? But it's scary. It's scary. I mean, I'll tell you, I went through, when I took my LMFT exam, was there anything about suicidality on there? Not a thing. Was there anything in my coursework? Not a thing. And that's the case with most academic. You maybe get a little bit of it in crisis counseling and a little smack, but you don't get a sustained exploration of how to deal with a suicidal client. And what's the most common situation we're going to run into when somebody comes to see us? The most commonly encountered situations is a suicide situation, suicidal behavior. And yet it's assumed that we will pick it up in settings like this. But if we're picking it up now, it's too late because we've already been unleashed on the public. We should have been prepared from day one when we opened the door. Make sense? So again, I got to be careful. We got to move on. So let me just kind of clarify. That kind of sets the stage of why we're spending some time looking at this. Let's clarify a little bit about the issue itself, because there may be some surprises here as we talk about this issue as it is in the military, preparing our way towards what do we do from a clinical side of things. Everybody see this? See the Time magazine? By the way, let me just remind you of something that was in that article. General Corelli. But what makes preventing suicide so confounding is that even therapy often fails. Over 50% of the soldiers who committed suicide in 4 years that I was chief of staff had a behavioral health specialist. It was a common thing to hear someone who had committed suicide who went to see a behavioral health specialist and was dead within 24, 48, or 72 hours. And to hear he had a diagnosis that said, this individual is no longer a danger to himself or anyone else. That's when I realized that something is the matter. Now I understand, you understand when we're talking about suicidality, that there is a fluidness to that. People can be suicidal, an hour later they're fine, 3 hours later they're not so fine. So there's, the nature of the beast is difficult to manage. But I also have to wonder, in light of what we just said, if there's not also some incompetence to that situation as well. Okay? So, that's where we are from a military standpoint. Inside the article, you find this picture. I want you to notice, there's a lot that we could spend some time, but I don't want to get too bogged down in statistics, but I want to draw, it's not going to work. I want you to notice the deployment over here. Does that surprise you? Only 38% of the people who have died by suicide have been deployed. This is not a deployment issue. Please hear this, because the media, there is an axe to grind in the media. This is not a deployment issue exclusively. Obviously, we understand it would be foolish for me to tell you deployment's not a factor. It clearly is, but it is not why people are dying by suicide. Half of the people who die by suicide in the National Guard have never been deployed. 64% of the people who've died by suicide in the Army have been deployed one time or less. Okay? So, gives you some of the trends up through 2011. I can tell right now I'm going to get sidetracked, but I got
What's the date of that Time magazine?
It is July 23rd of this year.
Thanks.
No, it just came out. It just came out. I went all over the place trying to find one. I got the last one at Barnes & Noble in St. Augustine. So, some of the trends, but again, I want to just throw something else in. Over and over again, you hear the rate of death by suicide in the military is more than and exceeds that of the civilian world. We just mixed apples and oranges. You cannot compare the civilian population with the military population for lots of different reasons. And I'm looking at one of the major reasons right now as I look at you. Any idea what that would be? I know you're not a military audience just simply by looking at you, and it has nothing to do with you whether you're wearing uniforms or not.
The way we're sitting in our chairs.
No, there's too many women in here. There's too many women in here. Predominantly, what's the population in the military? Huh? Well, do males typically, statistically, attempt suicide more often than females? I mean, just by virtue of that, don't we have a higher risk group if we have more and more people, males in the room, just by, just one small, fairly insignificant demographic?
They succeed.
Yeah.
The males succeed.
What did I say?
No, you
Oh, did I say?
said attempt.
Okay, completed. Thank you, because it is completed. Females attempt. But, so again, if you have an organization full of males, automatically, just from that one demographic, you have altered the risk factor of that group. And there's so many other things. And you can see that displayed here in terms of the trends, male and female, simply from that standpoint. This is the National Guard. I want to show it because it's good news. It's good news in the sense that we are down. We are down. One of the reasons why I want you to see that is, it's not excitingly down, but at this point we'll take anything that's a downward turn. You can see where we are as of
There's so
last
many
month.
in 2010 and 11. What was going on? Were they deployed?
This is all National Guard.
But July, August, 2010, 2011. Wow.
It's hard to know what drives in any particular. There was a period of time like last year, where all of a sudden nobody could figure out why for a 2-month string, all of a sudden the deaths by hanging just went through the roof and then came back. What's going on there? I mean, we'll be able to find out at some point, but right now it's too early to tell what the heck's driving those kinds of issues. But understand, about 40% of the Army fighting force overseas is National Guard. We've really taken the National Guard out of their sphere of what they were intended to do. Really, so it puts a lot of strain. Now, I say that because it's really important, because the National Guard is down, but what you need to understand is that when you bring back a group of folks and you separate them out and you have the active Army folks and the National Guard that deployed together, and you separate them out. Initially, when they come back to the demob station, they'll report roughly about the same level of behavioral health issue and severity. 6 months later, the active Army will remain relatively stable. The National Guard will skyrocket because they don't have near the resources. Active, I mean, let me give you one insignificant, well, not insignificant, but one data point. When an active Army person comes back to stateside, do they have a job? Yeah. They're active Army. When a National Guard person comes back stateside, do they have a job? Probably not, because the law regarding that is so loosey-goosey and so
They're not
ways.
guaranteed their job?
Not necessarily.
Something
No.
about
No.
a job, but not necessarily.
They won't have a job. They won't have a job. Yeah. Just a key issue. There is that, I mean, and think about the difference. When I come back, the sense of having confidence, I've got a job, and the National Guard guy's wondering, will I have a job? Just in that, think about the instability that's created there. The active Army family, again, I'm not trying to, but there's some real differences. Active Army person, family. While the Army guy's deployed, what does that family have access to? A whole base of services. National Guard comes back, what do they have? There's no base. They have community. Whatever's in the community, they're relegated to that. Because the National Guard provides no internal behavioral health treatment resources at all. It's all external. Okay? So think about the instability it's created. And so when you come back and how that exacerbates the situation for folks. Again, I don't want to say, oh, my National Guard people have it so much worse than the active Army. No, active Army has a lot of tough difficulties as well. But sometimes people don't understand the difference. Do you realize, I'm going to do it, I can tell I'm going to get off here. Do you realize the National Guard, when they come back, their insurance stops 180 days after they get back. They then have to buy their own if they want it. Well, if you don't have a job, what are you going to buy the insurance with? Now, I'm saying all that because I don't want to just throw out stuff. That's where you come in. They're going to be looking to you and what agencies can provide. Yes, sir.
Along that line, for those of us in private practice, when value officers took over the military one source, which is supposed to help individuals and families and pre-deployment demobilization, one of the key issues in there is you cannot identify a medical issue.
No.
No DSM diagnosis.
Right. Thank you for mentioning that.
That disqualifies military one source. I have it in writing. If you've done the training,
Yeah.
you know that. I've raised the issue with Rubio's office. Nelson hasn't responded. I think it's an absolute tragedy, idiotic waste of effort. And I'll tell you, I lie. I don't report. If I have a couple there for marital issues, And if the service member or guardsman has been diagnosed with PTSD, is getting treatment at the VA, I cannot report that because that disqualifies them from military one source.
Right, and just understand it's always been that way. Military one source has never been able to do more than V code kinds of thing. Again, but I also want to be careful to say there's a real place for military one source as long as we understand the role that it can play. And so again, a lot of folks think, well, isn't military one source, don't can't soldiers get that? No, if it's a medically necessary situation, they won't be able to handle it. So again, that makes you.
So where do they get help? They have to go back to the VA hospital?
They have to go to the VA or community organizations. And most of them, you know, I won't say most, a lot of them don't want to go to the VA for lots of reasons. So again, don't want to get too sidetracked, but that tells you how important you are in the scheme of things in terms of community. Again, just highlighting deployment, you look at that slide and what do you immediately notice? There's a real pattern there, isn't there? It is either among the never deployed, or we get about a year after deployment, which is just about right, because 6 to 9, 8 months the PTSD symptoms start to kick in because the decompression has begun to stop. You know, the deployment has started to catch up with them because, you know, their body's back, the rest of them still over in the war zone. It finally catches up, and it takes about a year when they're kicking the dog before they find out, maybe there might be some issues here. So that was one of the reasons why TRICARE extended the benefits to 180 days post-deployment, realizing that, but what we really know is that's not far enough. But just to understand that. So I want to just give you two quotations. Sorry for it being a little bit offset there a little bit, but you get the idea from both General Corelli and Major General Carpenter, National Guard Vice Chief of Staff. Again, both recognizing that deployments are not the issue in and of themselves, okay? These are just two studies. The red one is referred to as the Red Book if you're sometimes hearing people talk. The yellow one is obviously the Yellow Book. The Army National Guard's getting ready to release a study. It's going to be called the Black Book. So, you know, red, yellow, so just kind of keep on. Those are very significant documents, very extensive kinds of things. Pardon? I'm not sure if you can. I mean, I have access because I have an access card, but I think you might be able to Google those and find them. Somebody that's posted them. If not, my email will be at the back. If you want, I can send them to you. I have the PDF version, so we can send that to you. But again, just noticing in terms of deployment on both of those, there's been a little bit of a shift recently in terms of people who in theater or in post-theater with deployments are engaged in suicidal behavior. But again, predominantly hammering home that fact. Yes, sir.
About the last slide, could you clarify what it means to be deployed versus being never deployed?
Never deployed is that you've never left the United States, and you can also have a CONUS deployment. I mean, a lot of our National Guard get deployed to DC or other places. That would be considered a deployment, is to leave, go somewhere, provide a mission. A deployment or non-deployment would be folks who've never done that.
In theater means you're getting prepared to be deployed?
No, in theater is in country there, providing support. Right.
Does theater have to mean a war zone?
It doesn't necessarily, but for most military folks, theater equals being in a combat situation. You'll take some, and I don't mean necessarily in combat, but in a combat zone. Some folks who go down to South America who do anti-drug missions will also sometimes talk about being in theater, but they tend to talk more in terms of mission rather than theater, because theater denotes a more wide range of operation and coordination. So, any other question? Yes.
Mike, I haven't worked at Suicide Institute at James Head. I'm an intern there, so I'm kind of. I noticed that there's an uptick in active duty suicide now.
Right.
In 2012 Secondly, I have to go. Secondly, we have PTSD. I know it's the magic word, buzzword, but that's the real major one is depression.
Right.
So we have a tendency to, lock in on TPS. And one of the things I've learned as an intern is that I've got a chance, that you just said, Mike, is that where I work at, it's like I'm like an ER, but I get a chance to see the suicide. If it was a dang if it was a DSM, it'd be easier, but it's not. So in other words, if the primary care providers or providers there, they don't understand it because it's not a DSM thing.
Right.
It's more of a symptom with it.
Right.
So that's one of the things I see as well, that the primary care providers we probably have at the VA are not as familiar with suicide and all the symptoms.
We're really going to address that here in just a little bit. So thanks for bringing that up. So that kind of gives you that idea. I wanted to give you this because this is, I think, very relevant to what we're talking about. Really, in terms of the Army National Guard, I think there would be some validity, active Army as well, is that there really are two very distinct different groups. And if you'll notice again, the careerists only account for about a third of all suicide deaths. Obviously the careerist denotes exactly what you would think. The long-term folks, the folks who have a little bit more advanced rank behind them, have seen more numerous deployments, those sorts of things, and tend to have, because of the wear and tear, tend to have more behavioral health issues, and therefore tend to be on people's radar screen because of that. But now notice, 2/3 are among the first termers. Again, so people who have not had a chance to really manifest a lot of stuff, and therefore they're not on a lot of people's radar screen because there's no reason to be. And notice where the majority of the suicide deaths are occurring. It's within that group. So it's a little bit difficult because there's nothing necessarily noticeable to bring them to the forefront of people. Maybe a battle buddy or somebody, but not from somebody from a commander's perspective, an NCO perspective, or behavioral health person who may be helping monitor you. Nothing that's really putting them on the radar screen. So that makes it difficult. Okay.
I really would have thought those that were deployed would have been the opposite.
Yeah.
Are you going to explain later on what to look for in those that haven't been, or is there any answer to that, or is that one of the big questions is why that rate's so high? Because I really would have thought it would have been the exact opposite.
Yeah, it is. That's why I present this, because it's kind of like, whoa, this is not what the media has led me to believe. And we'll try a little bit, but again, understand that if we knew the factors, we would be more on top of it. We're still kind of going, what the heck is going on? I mean, even from a public health standpoint, we're still trying to figure out what is this? I'll give you my biases, but I don't have, Mike McFarland does not have answers here. I have more questions, but we'll play with some things that will help, I hope.
Group 2 also probably fit into the age range that we see in a national perspective, that 18 to 28 year where we see the predominant suicide as a completed death.
Right, which is Colonel Griffin's contention in this article is that, and he drew a lot of heat from this. He says, folks, what we're really seeing is a cohort effect. This is a cohort of folks moving through the military, and this is what we should expect. It is the high-risk group moving through. Because he said, when you look at my data, the 3 key elements that pop up is gender, age. What am I missing? Gender, age.
Race.
What? No, I'm forgetting what the other one is. But again, those things that you really can't do a whole lot about. And that's not what anybody wants to hear, because it's like, well, particularly the military doesn't want to hear, because the military, what's their orientation? There's not a mission that we can accomplish. There's not an enemy out there that we can't put down. And so that was not good news to hear. So it drew some criticism. I don't know if Colonel Griffith's necessarily correct, but it is intriguing to consider.
When it says prior service, Does that mean prior service just in the National Guard, as opposed to some people who do some military folks?
No, prior military.
Okay.
Yeah, in any branch.
Okay.
Yeah, because National Guard obviously get a lot of active duty
That's
folks
what I was curious
who
if that
come
was
over.
what they were talking about, or
Yeah.
just both.
Yeah, it's cool.
Okay.
What about the class, like prior to the crime of the older and the younger? Has it remained steady or has it increased in the younger?
It's still increasing somewhat among the younger. I mean, the profile still is there. The younger folks tends to be where this tends to happen. Yes.
Real quick, the last slide, I didn't understand what M-Day.
Okay, great, thank you. M-Day is your traditional soldier who drills once a month, and then when they're called up for duty, they then cease to be M-Day and they join into the active component. But your M-Day is your traditional everyday soldier in the National Guard. The other folks who will be in the National Guard who aren't M-Day will be your FTS, your full-time staff. I don't want to get into that because then there's AGR, ADOS, technicians, and all that, but they're full-time. So the M-Day are the people who go to work somewhere out in the community, drill on the weekend. Make it simple.
Does education have any bearing in the group number 2, young, uneducated? Is that ever true?
Education tends to be a factor. Yeah, we don't like to hear that either, but that tends to be a factor. Yeah. And you can really see that among the officers because that is just by virtue of the qualifications for officer. There's much more education, so there's some differences there.
I know the focus is on the National Guard. Do you believe that the National Guard does a better job of reporting the suicide events as opposed to other branches? Is there some
No,
disparity
because they all
there?
use the same system to report those.
Okay.
Yeah. So, and it's a pretty accurate, detailed system. So the data that the military is providing is pretty accurate. In fact, it's much more accurate than the public health. Because notice the most recent data I can give you from public health standpoint is 2009. The military is able to report as of last month. Wow, big difference. Which is another reason why you can't compare apples and oranges. Anyway, I gotta move on, folks. So what do? We've got all that. Have a sense of the problem. How do we then begin to think about a response to all this? I want to present to you some things from Dave Jobs. Not because I want to sell Dave Jobs' approach, but I think there's some real merit to some of the elements of his practice, and it's increasingly being adopted within the VA. And as we, in community clinicians, interact with folks in the VA, that helps us kind of speak somewhat of the same language. So I want to present some of the things out of his model. You take what you find valuable, not that you necessarily have to adopt the entire system, because I would never adopt anybody's entire system. I mean, just got to find out what works. So we'll talk a little bit about this because it does have some evidence support to it, beginning to get into some random trial studies that will, again, increase its power. But just want you to know a little bit about this. Basic 2 kinds of key points about the CAMS approach. Embodies an overall philosophy that's built upon collaborative alliance. We're going to come back to that because that is my pet peeve when it comes to suicide intervention kinds of things therapeutically. The alliance is everything. That's an overstatement, but it is so important. Okay? But then beyond that alliance factor, it then establishes some very specific procedures. And those procedures are designed to express that inherent value of alliance and to enhance it. Okay, so the procedures are related to this underlying philosophy. Okay, make sense? All right. So there's the foundational components. Operates on the premise that the alliance is not just a way to begin to start to get at treatment, but actually is a key vehicle of treatment itself. Okay? It changes the fundamental dynamic that can happen. Again, we're gonna ferret these out a little bit, but just look at those. The fundamental dynamic that can take place when you're talking about what's driving in the client who is thinking about utilizing suicide as a means to address that psychological pain, and the approach of the therapist, which is, I really would like to see some other kind of outcome. You already kind of get the sense of the power struggle that can easily develop in that kind of situation. This is a way to manage and address that potential power struggle. It conceptualizes suicidality from a very different perspective, from a phenomenological kind of perspective. The client becomes the expert in their own experience. I want you to help me understand what suicidality is like for you. I need you in this process. Do you see the collaboration that we're establishing? Mm-hmm. You are the expert, which is difficult because, after all, I got the degree. I earned this baby. I know. And you got to set that aside. Okay, we'll talk some more about that. And it centralizes suicidality as a central treatment target. And this is going to, we may get some pushback on this, and that's all right. Traditionally, we have looked at suicidality from the perspective that it grows out of, and that this is simply a symptom of some kind of psychopathology, depression, anxiety, PTSD. Wrong. We know that doesn't work. Axis 1, Axis 2 issues can certainly exacerbate, but just because you've treated the depression doesn't mean you've even begun to touch suicidality. Okay? So it looks at it from that standpoint. Not pushing it aside and saying it's of no relevance. We're simply taking it off a center stage. Okay? All right. We'll come back to that. I promise you. So let's talk a little bit about alliance. What we know about alliance is it is a necessary element to a positive therapeutic outcome, right? Stay with me. Yes, thank you for body language.
Yes.
Stay with me. Help me. Stay on board. Wake up. Right? Therapeutic alliance is a necessary component for a positive outcome. You can't have a positive, I mean, therapy is about engaging, encountering human to human. Got to have it. And so, this can be challenging given the attitudes that many clinicians have about their role in the relationship. Because wearing that white coat is powerful in the eyes of the clinician. I am the expert. I know all. I know the DSM-4. I eat, drink, sleep. You know. And the tendency is then to see the person across from me not as a person, but as diagnostic criteria. How many times, maybe not you, I've been guilty of it in the past, how many times instead of talking about my client this, I say, my borderline, what have I just done? I've assumed a human being to dehumanize. And so that's sometimes we have to be careful with that from a clinical perspective. Okay? And then also, in terms of the alliance, one of the things that gets in the way is that sense of lack of competency. So there's a great deal of discomfort because I'm sitting in the situation, it's a suicidal situation, high risk situation, pardon my language, I don't know what the hell I'm to do.
want you to tell me you're okay so you can go out the door.
Absolutely. Absolutely.
Sometimes we
Absolutely.
kind of guide them
And so
say the right word.
I don't connect with you. I don't dare go into the depths of where you are in terms of your experience, because I'm too afraid as a clinician to go there, because I don't know if I'm going to get in a hole and can't get out. And so if I can't go there, I can't connect with you. And if I can't connect with you, we're not going to have good therapeutic outcome. Make sense? Okay. Again, I don't make money from any of this, but I would say one of the absolute best books I've read recently devoted to alliance and suicidal clients is this book here. Yes, Dave Jobs. Dave Jobs is not my dad, but anyway. But he and I, we really kind of tune one another. But this is not by Dave, but I would encourage you, if you have an interest in really digging into understanding alliance, this looks at it from a lot of different facets. What drives this book, and I won't take time to really get too much into it, but what drove these clinicians to write this book is called the Ashby Group, because they first met back in 2000 in Ashby, Switzerland, because they began to look at the clinical climate of the inability to address suicidal clients. It concerned them so much is they said, we've got to get together and talk about this. And what drove this is as they began to review cases from various parts of the world, they were coming up with the same thing. Alliance is missing. Alliance is missing. And so that became kind of the drum to beat. And I'm not one to read a lot of quotes, but I want you to notice two things that come out of that book. The fundamental importance of a collaborative professional relationship, the alliance, tends to be neglected, particularly in an age of managed care, time pressures, and tendency to reduce human suffering to mere diagnostic entities. The crucial value of listening to patients, learning from patients, and trying to understand what hurts is too often never properly taught or learned or used. Let me give you a real quick example of this. I was providing this kind of information to a group of graduate students in Kentucky, where I'm from, counseling students. We spend a lot of time on alliance. I'm not going to say. We were spending a lot of time on alliance and dealing with suicidal clients. All of a sudden a hand goes up. Yeah. Sir, when are we going to get to what really helps? What that individual was looking for are what are the tools, what's the tricks, what's the gimmicks that I can use, you know, rather than this is the tool. Human beings connecting. Case in point. Okay? Notice, our main concern has been the strong impression that with the contemporary and ongoing changes in clinical practice, the art and skill of establishing a therapeutic relationship may be in danger of getting lost altogether. So again, you see the critical element is that we have a mounting suicidal issue. We have this concern out there in the therapeutic world that developing alliance is being lost. And if it is, in fact, a key issue in addressing suicidal clients, there's a problem. Oh, you guys are so smart, I don't need to explain that to you. Now notice, whether actually conscious of it or not, what a suicidal client is hoping, they might not have this overt awareness, is they really want a relationship, a connection. Because a lot of what's driving suicidality is a sense of disconnection, isolation. Okay? And so there is that sense. And so they're already, what's driving that sense is underlying, and part of what you can help them do is to discover that that's in fact part of what they are looking for. And that you can begin to provide that in such a way as to launch them into a different direction. Because you get it. This is not about your 296.1. This is about you needing a connection with the person and feeling connected. All right? Because that's what they want. They don't want you to provide treatment in light of their diagnostic element. They want to be seen as a person, and treated as a person, connected to as a person. And so when you think about it, what drives a large number of triggers for suicidal behavior is what? Loneliness, isolation, and that what's the triggering is the loss of some kind of relationship. The vast majority of suicides in the military have, in connection with that behavior, the loss of a relationship. Through death, through divorce, through whatever means. Or the death of a loved one. All of a sudden, somebody important to me has become lost. And that knocks us back, doesn't it? Because we are wired as social creatures. It's crucial to our well-being. As therapists, we know that. So that's the issue. But too often in all that, what happens is they come looking for help, and they're engaged by someone who has this distance about them, because I am the therapist. And so it's a one down kind of proposition. So let me come back in just a second. So it's much like this.
Could switching to Geico really save you 15% or more on car insurance? Does a former drill sergeant make a terrible therapist?
That really makes me sad, I think. That's interesting. You know what makes me sad?
You do! Maybe we should chug on over to Mamby-Pamby land, where maybe we can find some self-confidence for you, you jackwagon! Tissue.
15 minutes could save you 15% or more.
No, I don't sell Geico insurance. But you get the sense. You get the sense of what happens. I mean, I've talked with veterans who said, I will never go back, and I don't want to say the organization because it's not necessarily indicative of the organization, but I will never go back because that doctor, that therapist was not listening to me. They were listening to diagnostic criteria. Of course, they don't say that, but they were listening to a list. They were ready to push medication on me and get me out of the office. They were not engaging me. And I also understand, when you've got 95 people out there in the waiting room, it gets tough to say, okay, I'm going to connect with number 34 today. And you're exhausted and you're really worn out and you kind of tend to, but the bottom line is, when it comes to suicidal clients, it's about engagement. We can't lose that human perspective because that's what they want. That's what they're looking for. That's why many times they are where they are, because there is not that situation. Okay? Yes, sir.
And the first time our client mentioned, I'm thinking about hurting myself, we reach in the door and pull up the Baker Act for it.
Thank you. I got the true story. I sent a community provider one of our soldiers, and he called me back. He says, "She didn't get it. She didn't get it." I called and I said, let's talk about what's going on. And that was her sense. Is that when he starts talking about suicide, you got a Baker Act. I'm going, maybe not. Have you spent enough time figuring out if that's really where you need to go? Oh, well, no. I mean, and that's what I said. She goes, no. If somebody starts talking suicide in this office, we Baker Act. Well, I'm thinking you probably don't have many suicidal clients because nobody's going to come near your office. And my sense, yes, Mike, I'm overreacting, jumping the gun. My sense was that's driven by a lack of sense of competency. I don't know what to do with this, so the safest thing to do is to cover my butt and send you to But not only does that traumatize the client, it also ties up precious resources because we now have somebody taking up a bed who may not really need it. And we've turned them off to the mental health system because it's like, man, you do that to me, no way am I going to come back to you. Now sometimes it's legitimate. You've got to do what you've got to do. But many times we do that more than we really need to because, and that's what's driving that initial article by Dave Jones, is we way too much depend upon the hospital. We've got to learn to manage. You can successfully manage pretty high-risk people in an outpatient situation if you're willing to provide what needs to be provided. And yes, it takes some doing, but boy, you sure develop a relationship when a client knows you're working your butt off to keep them out of the hospital because they don't want to go there. And if you're willing to work, they'll work with you 99.9% of the time. Yes?
I know that I work with adolescents, and one of the things I find interesting is the school system tends to Baker Act them a lot. And so a lot of times they'll come to me and they'll say, I'm not going to say what's going to get me Baker Acted, okay? Okay, you're not going to Baker Act me. And that's how we start the conversation. I'm like, yikes. But I also know that when those young people become adults and they've had that experience, they don't want to talk to you about depression because they're afraid you're going to Baker Act them.
Right.
Yeah.
Yeah, I mean, so if we're going to have honesty in this room, we've got to really deal with that, because if you're not giving me everything that needs to be given, how can this be successful? How are we going to have a positive outcome if you're withholding? How can we really provide treatment and address what needs to be addressed if you're withholding? That can't be good for you. It's certainly not good for me as a clinician. Yes?
I work at the VA, and the patients that I see are from the National Guard and reservists, and a lot of them, they won't really say a lot about that, only because they might be reactivated. They don't want that in their records, because they have this idea that DOD and the VA are connected.
You're military. They think you're military.
Yeah, so we're going to tell on them, and we're going to let them know that, oh, don't deploy because they're not right in the head kind of thing. So it's really hard to try to get them to trust you enough so that they don't think that you're going to rat them out, because they want to get deployed a lot.
So you have to do a lot of earning. And I remember in your slides, you talked about trust and having to earn that trust and develop that trust. So, yeah. But so there is this dynamic, this potential power struggle that can develop, right? I know what's going on inside of my mind. I'm thinking this is the way to deal with it, to die by suicide. And I know what your job is. And so we get in this power struggle. Yes, I want to die by suicide. No, you won't. I won't let you. No, you can't. This is going to sound heretical, okay? My bias is, I'm going to label it that way, my bias is coming to the recognition that that person across from me who's thinking about suicide can always do that. I will never cooperate with it, but I also know that I can never remove that possibility. It is always an option, isn't it? Right? So if I quit pulling, it won't happen, I can't let it happen. If I just let go and say, it's an option for you. I understand it's a powerful option for you. It's very seductive to you. And we'll talk about this here in just a minute. But if I lay out in all the options that are in front of you, this is the one that you are feeling pretty strongly about. And it is an option for you. What I'd like for you to consider is, as we explore this, is this your best option? Maybe it is. You'll have to be the judge of that. But will you give me some time to explore to see if it is? Now, what have I just done? I'm not going to pull. I also will be very clear that if I sense that you're in imminent danger, we will go to the hospital. We're not going to play that game. But anything short of that, anything short of imminent danger, and yes, okay, Mike, what do you mean by imminent danger? Good question. Try to figure that one out. But there's a lot of latitude to work, right? And if I can kind of get them calmed down that this is not necessarily going to go to the hospital, if I can get somebody on board working with me to keep them out of the hospital, wow, that's a pretty powerful situation, right? Because if you've got a suicidal person working with you to keep themselves out of the hospital, boy, you're 65% of the way there. Because what they don't know that you'll bring out in therapy is you already have them working to save themselves. So maybe that desire to die is not as strong as it may appear right now. So we're talking about ambiguity, ambivalence. Okay? So anyway, we'll talk about that here. So we've talked a little bit about the alliance. Talk about collaboration. That picture was chosen on purpose. You can't do that without collaboration, can you? It takes two. And it takes two in the therapeutic enterprise, particularly in terms of working from a suicidal standpoint. I have to have a client on board. If I'm constantly pulling, tugging, pushing, coaxing, I'm not getting anywhere. I got to have them on board. And so the traditional approach is, as we've already suggested, to be the one up, and the client is the person down, and I'm the expert, and so it's expert driven. And so what happens is then the person doing all the work is a therapist, and the patient's pretty passive. And really, as I see the client, their only role is to sit there and manifest symptoms. My job is to figure out what, where you fit in the criteria, and then come up with a treatment plan. I'm doing all the work. I need collaboration. So that's more of the traditional approach. The CAMS approach says, no. What I want to do is I want to sit beside you and I want to look at this issue of suicidality. You guide me. You help me to see it from your perspective of what's going on. I want to see it through your eyes, not through what I learned in college. Okay? You become the expert. Okay? And so the gold standard in the CAMS approach is the client's own experience. That's why it's phenomenologically based. And we'll talk about how procedurally that gets borne out in the process. But you're going to drive this thing for me. And also, you can also see from that vantage point, what are we doing? When I adopt that kind of stance, and what I'm going to show you here in just a minute is this is not just a theoretical stance. In therapy, I actually sit beside you, not across from you, in the assessment process. Because I want everything in this room to say collaboration, we're in this together, we're co-authors, we're equals, we're going to balance the playing field here. And that really, really feels good for a soldier who doesn't really work well in this behavioral health world anyway. You're a suspect both from a civilian standpoint, as was already mentioned, and you're also suspect because you're one of those shrinks. But if we relinquish all that and say, hey soldier, you guide me, you help me understand. I'm going to sit beside you, here's the reins, let's go. Wow, that's just so disarming. Make sense? Okay. So that's kind of what we're aiming at. The other thing that it does is that when I'm sitting beside you from that standpoint, this whole suicidality now is getting externalized, isn't it? We are looking at it rather than me looking at you and saying, oh, that ugly stuff going on inside of you, which makes you ugly. Right? It makes you dysfunctional. See? Does that make sense? Okay. You got to cue me or I'll sit here and drill forever. So, as we start this process, it begins with the assessment and that being collaborative, because right up front, we want to send the message, this is not about me being the professional, this is about us working together. And so I want to engage in a way that enlists their narrative right first. And this is tough because that intake, what do we have? We have all of the stuff we got to gather, right? And this is where it becomes difficult because I may have to delay this over a period of several sessions before I actually are able to come up with what I need in terms of diagnosis. Because I need to spend some time enlisting the story from you and getting your narrative. And what does that send to the client is, what's important to me is not the information I need to get to function as a therapist, but you and your story. And probably 99% of the time, if I listen to their story, I will get all the stuff that I need. We just don't trust ourselves to capture it in the note, so we've got to go down the list. And that's where competency comes in. Okay? So, you can see all that, so I need to kind of... The other thing is that it conceptualizes suicide differently. Remember, we talked about how the traditional model is to say that suicidality is really about the psychopathology, the depression. Well, those are simply components, features, exacerbators, but they are not what defines necessarily suicidality. People can be suicidal and not have an Axis 1 diagnosis. And you can treat the pathology and not address the suicide. So if suicide is the issue, it needs to be a treatment element. It needs to be the number one on the treatment plan. Addressing that directly. Make sense? Okay. Let's see, where we at? I think we've pretty much, yeah. It is about understanding the sources of the pain, what we would call the drivers. We get the psychache, right? Everybody familiar with what psychache from Ed Schneider? That sense of psychological pain that drives primarily the suicidal actions. And there are things that are driving, festering that pain. It could be partly depression, but many times it's psychosocial kinds of stuff. My girlfriend left me. My wife died. I just got busted in rank, which is a loss of a relationship. Okay? So all those kinds of things. So while we always hold out to the client that, yes, suicide is an option for you. I can't take that away, can I? It is always an option for you, but what I want you to be thinking about is it your best option? Because if you're going to address your pain, doesn't it make sense? Let's do it the best way possible. So, again, we talked about that. Gold standard. What else do I want to hear? I think we've pretty much covered that. In this assessment process, what we'll see here in just a minute is that we're also assisting them in deconstructing their own suicidal thoughts. Because the better that I can help them understand these thoughts, how they're working, because they do serve a functional purpose, don't they? If you can help the soldier understand that you get it, let's address it rather than fight it and say you shouldn't have it. Let's go with it. They're more empowered. And so it talks about, we talk about targeting it directly. I think we've pretty well looked at that. So we're going to look at, that's kind of the conceptual element. Let's look at some of the procedures then that support all of this. We'll talk about the first three of these. We won't have time to get into some of the more treatment-oriented kind of things because I just wanted to give you clued in on some of the basic elements. An important caveat, as you look at this, notice the title of this book. It's Managing Suicide Risk, a Collaborative Approach. This is not so much about a treatment protocol. So if you're a cognitive person, you can still utilize this. If you're a psychodynamic person, you can still utilize it. That's what I mean by non-denomination. This is meant to be an approach within which you can package your particular stripe.
Once you get them to verbally agree that suicide might not be the best solution, do you have them sign a contract before they leave your office?
No. We'll talk about the contract here in just a minute.
Okay.
So, early identification. If I'm going to spend time doing this, and and I need to find out if suicide is an issue, because I don't want them leaving the office without that being addressed, I need to do it pretty quick. Right? 2 things within the first 10 minutes. And the way that you do that is that you need to have out in the waiting room some kind of screener that will cue you that it's quite possibly an issue, so that you have that early alert. You're not always going to get a positive. Sometimes you get a false positive, but at least it's an attempt to get early warning. But I want to raise this issue, particularly if I'm talking with a soldier. So people say, wow, man, you talk about therapeutic alliance, and that popped in the question pretty early. Well, I don't want to be doing it at minute 49 in a 50-minute session either. You learn how to say it in such a way that it is alliance building, because that's really saying, this is so important to me. You are so important to me. I want us to get right into this. And it also says, I'm not afraid to go there. Be direct. You don't bring it up to minute 49, you're telling the client, I'm afraid to go there and I've put it off as long as I can, but I got to check this box. Make sense? Right. When I say make sense, I'm not saying you have to agree with me. I'm just saying, am I making sense? So you have the screening tool, those kinds of things. But you find with that tool then a way to make an easy transition. Hey, I was noticing here you indicated on this. I'm just wondering, and associated with that, if you've had some thoughts about suicide. Either recently or in the past. Very nonchalant, matter-of-factly. Because if you sit up in your chair and give them all that attention, all of a sudden, like, whoa, this guy's ready. He's going to open the drawer and pull the Baker Act out. And you can always say, and before you answer, I want you to know, if it's a yes, it doesn't necessarily mean hospital. We've got a lot of time here to figure out what your needs are. Did I lie to them? No. But I've also tried to answer what I know is going to go off in their head. Hospital, hospital, hospital. And I didn't say we wouldn't. I said, let's see. But it is not a necessary element. Okay? So, now, if you have in your handouts, you should have something that looks like this. And I tried to, when I copied these, I thought I had adequately put across their sample, so please be respectful of the copyright. Dave Jones has given me the permission to hand these out, but after I came back to the copy machine, I went, oh crap, it's not on there. So please don't reproduce unless you buy the book. If you buy the book, then you have automatically the license to reproduce them. Okay? It's the very first one, suicide status, yeah. I want us to talk a little bit about what this looks like. But before so, I want to demonstrate David in showing you how this setup looks like in terms of
this young man who's
Dave Jones
presenting to a CAMS provider.
Not a good video, but because it's a video of his video.
Well, sir, my wife is pretty concerned about me. I've had some trouble since I've gotten out. I got out about 2 years ago. And I just had some trouble adjusting since then.
Some troubles?
Yeah, just some of the things that I did and kind of happened while I was deployed. Just kind of I had a tough time, getting rid of, kind of putting a lot of that stuff aside.
Your wife is concerned?
Yeah, she's worried about it.
How bad? So you see sort of a typical presentation, kind of there because he has to be. His wife told him that he needs to seek out some help. this guy is preoccupied with a very particular firefight where some civilians were killed and some children. And it really haunted him, not when he was in Iraq, but when he came back. And that's really been plaguing him. So we're really looking at initial presentation that's not out of the ordinary. But what I want to get to is how we then think about looking at ideation in the CAMS approach. And just give you some snippets of what this may look like.
You know, one of the things I noticed in the intake form is that you got a lot of symptoms of distress, and among those, that particular caught my eye was that you've had some thoughts of suicide, and that's not uncommon, you know, for guys coming back who've been going through some of these things that you're experiencing.
Yeah, I mean, just like I was saying, some of the stuff that, you know, that I saw, that I did, that, you know, didn't bother me as much or I didn't think it bothered me as much at the time, but it kind of, you know, I seem to be growing a little bit, it kind of getting worse and worse, and time goes on, and it's just, you know, I don't know what to do about it. You know, I mean, I'd say my wife is, you know, kind of really concerned about me, wanting me to come here, but you know, it's really, when me and her kind of, you know, at each other all the time. I mean, you know, it's my fault. I mean, because, you know, you're the problem. Yeah, I created all this havoc.
Well, one of the ways that we think about this, or I do at least, working with veterans, is that when people have this much distress, it's not uncommon for them to have suicidal thoughts as a way of feeling like there's something to do about it. And, you know, for me, what's really valuable is to understand more about how things get to that level, where it's so distressing that checking yourself out, you know, might be really an attractive way to go. And so, does that make sense?
Yeah, I mean.
Okay, so we're now getting into his suicidal thinking. And the goal here is to not shame or blame him for having these horrible thoughts. The goal is to be empathic, to understand that these thoughts do occur. Doesn't mean I'm signing off or saying that this is the way to get your needs met, but it does mean that I appreciate that these thoughts do occur and that they're real to you. So we're going to move now into the actual administration of the suicide status form. This is all first session. This is all happening within the first 10 minutes.
So one of the things, Keith, that I like to do is to drill into that a little bit further and figure out more how things have gotten to that level, to have a sense about, you know, really how distressed are you, and then what can we do to help you get those needs met? You know, the need to be not haunted, the need to not have your wife upset with you. And to do that, we've got a particular assessment here that I'd like to do with you that I think will help us get into more about what that's about. Is that okay?
Like specific stuff?
Like specific stuff. Because my sense is, if we can understand better.
Okay, so now we're sort of ramping up to the point where we're going to introduce the suicide status form. Again, this is just a snapshot of the first part of this engagement, but it's meant to be different, especially when we really now drill into the assessment of what's going on for him in terms of risk.
And to do this, if it's okay with you, I'd like to actually take a seat next to you so we can do it and fill this out together.
Okay.
Okay. Now, this is an assessment tool called the Suicide Status Form, and there's different questions here that involve different kinds of rating scales and different kinds of ways to respond. And what I find helpful about this is that when we kind of work our way through this, we'll get a sense of what's really going on with you. So for example, if you would help me actually literally fill this out, under this section, I'd like for you to rate your psychological pain, and then for each of these questions, fill in the blank as to what's most painful. And we're just going to work our way on through this. And if you have any questions, or if we can clarify this as we go, that's sort of my job, is to help figure this out with you. So right now, as we sit here and as you're reflecting on this, what would you rate your psychological pain from 1 to 5? 1 being low pain, 5 being like jumping out of your skin.
Okay, you want me to write on?
I'm going to move on, but Sarah just said we've got running out of time. I thought I had about 15 more minutes. Do you get the sense of how this is operating? And how taken back he was that you're going to, you want to sit over here, and how, he actually turns loose of the clipboard and hands it, says, we're going to look at this together, we're going to fill this out together. You're going to see what I write, I'm going to see what you write. There's total transparency there, developing that relationship. We're going to get an idea of what's going on here. See how that really is creating an environment that is not so much about going to the hospital and all of that. Now, if you flip over to the next page on your handout, there is a section where you get into that suicide-specific kinds of things in terms of frequency, duration, severity, those traditional kinds of probes. Obviously, that's necessary, but that's not what comes first. You're getting a sense of how it is from a phenomenological point of view as it comes through the lens, obviously, of the client. And you're getting some real key factors here. And again, I won't have time to go through all of this. But notice the psychological pain, that comes from Ed Sneidman's concept of psychache, agitation, and stress. Those are all concepts that come out of Ed Sneidman's model. The hopelessness comes out of Aaron Beck's model in terms of hopelessness is a key driver. Self-hate, that sense of wanting to turn on oneself, is Baumeister's perspective. So all of these are borrowed from various models coming together to give us a relevant picture from this client's perspective of what's going on. And then they write a statement there that will be key to help me understand, okay? Gosh, let me just try to figure out where I want to go to. Notice the other thing is the reasons for living, reasons for dying.
Take about 10 more minutes.
Okay. Reasons for living, reasons for dying. Really important to get that on board. I want to know, what are your reasons for living, reasons for dying, and I want them in that order. I don't want to talk about dying first. I want to talk about living. But then notice how impactful that is for the client to be writing that and to see, I do have reasons for living. I want to know what your reasons are for living because we're going to magnify that in treatment. But I also want to know what your reasons for dying are, so that because we want to target that in treatment. So it is assuring the client what aches me is going to get addressed. And it's what I tell you, not what you decide. I'm developing my treatment plan, aren't I? Make sense? Wow. You mean you put me in charge of therapy? Pretty empowering. So there's no psychological shenanigans going on here. You are helping to guide your own treatment and all of that. So, the wish to live to the following extent, the wish to die to the following extent, what is that about? I want to know what the client's level of ambivalence is, because it is there in every suicidal client. I do, but I don't. I want you to see it. I want to know it. We want to. Yes, that's a very subjective kind of statement, but it's subjective because what you say is important. Yeah, very important kind of stuff. We've got all that. So, we'll skip that because I've pretty much said that. That's Ed's model. We jump through this. We've looked through, I've already kind of walked you through the form from a perspective. We won't take time, but if we had, here's Hank's, you have a copy of this. This is Hank's actual responses to what he put on the assessment. And look at the kind of information here. Not only do I have his statements, his scaling, but I also then have, him telling me what's the most in terms of rank, in terms of importance. Notice the reason for living is a relationship. Well, I sure want to make sure that relationship stays good and healthy. I want to highlight that. Burden to the family. Number one reason for dying. So that's where you need to spend a lot of time as to what's going on there. Where does that come from? What's driving it? What's that experience? Ashamed of myself. What might that be about? Perhaps some things that he may have done overseas.
Or that he can't get better.
Or that he can't get better. That feeling of disability. But you'll tell me what that is. But I'm cued, that's where I need to go. Instead of what I know in the literature or what I know as an expert, I'm going to go there because you told me to go there. Okay? Anyway. This is all the necessary information that kind of gives me a sense of kind of where we are, gives me a baseline to go from, because particularly in terms of frequency and duration, if I'm dealing with somebody who is chronically suicidal, the first thing that's probably going to abate is not the frequency, but the duration. They may have thoughts about suicide every day, but what's really alleviating is that what used to last 2 hours is now lasting 45 minutes. That's a sign we're getting somewhere. So that's what that's all about. So we've got all that. Let me just kind of, because I want to be respectful of time, let me just conclude with this. Okay?
There is a question, Dr.
Yes.
I have a question on this last page. So would you take the pen back that it looks like, because it says
Right, I will, but I'll fill it out in front of him. I will write what they tell me to write, because there's no secrets here.
Okay, because you both signed it at the end,
Right.
but then you take the pen back and go through it. Do you ever not do this when you see from the front page that there's really not a problem?
I would have never started it. If suicide is not an issue, we would have never gone here.
Okay, so
Yeah.
you always fill out.
Right, right.
Okay.
The point is, when you look at this entire handout, your note's done. You don't have to go back and write a note. It's all right here. Everything you need. Done. Your client helped you get your work done. So anyway, I want to come to one very important thing, because I want to be respectful of time to close. Obviously, when you come to the treatment plan, you will see one of the necessary things that has to be addressed is safety. Okay? Look at developing what we have there for you in terms of a crisis response plan. Don't go the route of a no suicide contract. There's absolutely no research evidence to support that at all. Okay? And if you want the research, I'll be happy to dump it on you, because it is there. Lots of things we could go to. So that support plan. The other thing is that a part of that support plan, this is very important when it comes to the military, you need to address, and we know from research it is not typically addressed by therapists, is before that client walks out of that room, you need to have a very good, solid discussion about access to lethal means, particularly a firearm. Okay? That's not a conversation that happens very much. What's going to happen with that firearm? What are we going to do? Am I ready to relinquish it for the course of treatment? That sort of thing. Because if I've got an individual, think about this, if I've got an individual who's thinking about ending their life and they've already told me that the means that they were going to use is a firearm, and I allow them to continue to maintain that firearm, I'm complicit with their actions. If you don't want to turn loose the firearm, maybe you don't really want to do treatment. So we need to talk about that.
And what do you do? Do you have them turned over to you?
Well, one of two things. If we can't find a way to collaboratively make that happen, either I'm going to have to make the decision, maybe you're more imminent than we have discovered, or which is a choice, and I'm going to get backlash for this, you don't have to be in treatment. Maybe you don't need to be in treatment, at least with me. Now, I'm not going to just drop you. I will see you. I will help you get connected with another therapist who may be willing to treat you anyway. But my values are, I'm not going to be complicit with this, because if we're about saving your life, you don't hang on to something that's going to contribute to that, at least for the time of treatment.
Where do you have them go with it, and how do you know that they have that?
We work out a contract in terms of somebody's going to call me to verify. We're going to get some verification that that's been dealt with. And I'll tell you, and I'm going to end with this. I promise, Carl, I'm going to end with this. When the VA has done studies with soldiers, they will tell the VA, we hate it that you have these discussions with us. But they also say, we understand that you need to do that. And it's a tough one, because for a military guy, to put away the gun is a big one. You have to think through with them and not fight them. Use your counseling skills to stay collaborative without getting locked into it. But at the end of the day, it's your choice. But I also have a choice as to whether I'm your provider. We'll continually evaluate that. And that's another way to help. We're going to constantly be looking at when is it safe. I really jumped the gun, but appreciate the time. Thank you so much. Wait.